Welcome, everyone. I'm Dr. Erica Wright, Associate Director of the HEAL program and the Narrative Medicine program and faculty here, as well as at the University Park campus. I'm really happy to welcome Dr. Melody Glenn. She's going to read from her book today, Mother of Methadone, which is described as a hybrid memoir that weaves her own story as an addiction physician with that of the history of methadone maintenance and its founder. Dr. Glenn graduated with her MD from University of Southern California, Keck School of Medicine. Yay. She completed her emergency medicine residency at Maricopa Medical Center and earned her EMS fellowship from the University of California, San Francisco. Triple boarded in emergency medicine, EMS, and addiction medicine. She's an associate professor of the University of Arizona College of Medicine, medical director for several fire departments in Southern Arizona, which seems like a big deal these days. The director of addiction medicine consult service at Banner University Medical Center in Tucson. The director of outpatient addiction medicine, Whole Health Clinic, and board member of Cochise Harm Reduction. Dr. Glenn also has her MFA in prose from Mills College, and her work has been supported by the Elser Artistry Residency in Mexico City, a grant from Arizona Commission on the Arts, and she's been nominated for a Pushcart Prize. Her articles have been published in Salon, Time, Literary Hub, Mutha Magazine, and the Arizona Republic, and are forthcoming in The Believer. We're thrilled to welcome Melody back to Keck. After she reads from her book, she will be in conversation with Dr. Pamela Schaff, who is the director of the HEAL and Narrative Medicine programs, a clinician, and has her PhD in literature and creative writing. So this will be a wonderful connection between the humanities and medical education. There will be time for question and answer and discussion. So thank you.
Thank you. And I will turn it over to you to read.
All right, thanks. And also, it's so exciting to be here with Dr. Schaff. So it was Dr. Schaff who got me back into writing. I took her narrative medicine elective during my 4th year of medical school. And without doing that, this never would have happened. So thanks. So I'll start by reading some pages. This is how we often do book events. I don't know if you guys get off campus that often, so we're bringing it to you here. Sort of different than the traditional lecture format. So I'll start with reading some pages to give you a glimpse of what the book is about. All right, so I'm starting from the beginning, and this is in 2020, the clinic. When I first neared the nondescript 2-story building, I wasn't sure I was in the right place. There was no sign labeling what lay behind the drab stucco walls, and the windows were too few and too small to catch a glimpse. The clinic itself seemed ashamed of its own existence, or perhaps just worried about what the neighbors would think. The parking lot was surrounded by barbed wire and patrolled by a police officer. In the corner, just behind a tall iron gate, a group of patients gathered. In the center, an older woman lay on the pebbled ground, talking loudly in a scratchy voice between drags from her cigarette. A man wearing stained jeans and holding an extra-large Circle K cup stood beside a younger woman in flannel pajamas and chunky black slides. The officer had also noticed this congregation and was walking toward them. According to a posted sign, no loitering was allowed on the premises. I guided my bicycle to the rack behind them, a little worried whether it would still be there when I returned. It was January 2020, and I was applying to work part-time as a physician at a methadone clinic. Primarily an emergency room doctor, I had become increasingly interested in addiction medicine over the past few years. To gain credibility, something I was always chasing as a young woman in medicine, I decided to pursue board certification in the field. This meant that I needed to work at least 500 clinical hours in addiction, and in Tucson, the only place looking for help was a methadone clinic. I had never imagined myself working somewhere like this. Methadone clinics weren't exactly seen as desirable. Nobody in my medical school aspired to work at one, nor was it presented as a career goal that we might strive for. But here I was in a nice dress and leather boots with freshly washed hair, ready for an interview. Swinging open the tinted glass door, I entered the buzz of the crowded waiting room. A line of patients formed to my right, waiting to get their daily doses. The air smelled of stale cigarettes and cherry cough syrup, the flavor added to the liquid methadone. Many of the patients had sunburned shoulders, and a few had cheap, thin roller bags that they dragged along beside them, signs of housing insecurity. To my left was a sea of vinyl chairs filled with patients waiting to see therapists, clinicians, or lab techs. Several times a year, patients were randomly selected to give a urine sample to determine whether they were still using drugs. They peed into cups, held over toilets, with silver handles taped in place to remind them of the rules, which were printed on a piece of paper, highlighted in yellow, and tacked to the rear wall. No flushing the toilet or running the faucet, even though there was no sink inside the small bathroom itself. There was also no lock on the door. The freshness of the sample was verified by a flimsy thermometer attached to the cup. The printed rules also detailed what happened if someone couldn't pee within 3 minutes. If they decided to leave the clinic instead of waiting in the lobby and trying again, a staff member would watch them urinate when they next returned. If my doctor asked me to follow such condescending, punitive rules, I would be outraged. I would demand to see their policies, argue with the staff, or storm out. But if you wanted methadone, there was no choice but to comply. Then, now that I've set the scene of the methadone clinic, I'll skip ahead to after my interview. When I returned home, I began my search for an origin story, suspecting that my seemingly personal unease around methadone was actually a reflection of something much bigger. When did methadone treatment first come onto the scene? How was it received? On the front page of an old JAMA article commemorating the 40-year anniversary of methadone maintenance, a black and white photo of a female physician caused me to pause, to look closer. She was about 60 or 70, joy radiating from her eyes. Perhaps this is what it looked like to be proud of your life's work. She was seated in a library, her bangs swept to one side, her hair cut short around her face. Bracelets adorned her slim wrists, and she was wearing a white button-down blouse tucked into a high-waisted skirt. A large pendant in the shape of a rounded cross hung from a chain around her neck. Her name was Dr. Marie Neiswander. Beside her stood a balding man with a closed-mouthed grin and a long white coat, Dr. Vincent Dole. Together, they had developed methadone maintenance. Later, I would learn that they had also fallen in love while spending long hours together in the hospital, when she was in her late 40s and he in his late 50s, and that he was her fourth husband and she was his second wife. But this article only mentioned them as research partners. The article focused on their landmark 1965 study in which they proved that daily methadone could treat heroin addiction, relieving cravings and allowing people with addiction to return to stable lives. At the time, nobody else in the United States was researching or offering maintenance treatment for addiction, mainly because it was illegal to do so. Instead, treatments were abstinence-based and predicated on the idea that addiction was a moral failure or evidence of psychopathy, and relapse rates teetered around 90%. But with their study, Neiswander and Dole suggested that addiction was a medical disease for which they had a successful treatment. One addiction physician described the results as equally monumental as the discovery of the first antibiotic. Although methadone maintenance was lauded as the panacea to end opioid addiction forever, the opioid epidemic today is exponentially worse than anything Dr. Neiswander could have imagined. According to the CDC, more than 2 million Americans have opioid use disorder, and fatal overdoses have surpassed motor vehicle collisions as the most frequent cause of accidental death. In 2021, over 100,000 Americans died from overdose. What had transpired between Marie's time and now? How did methadone fail? In the article, Dr. Mary Jean Creek, an addiction physician who worked with Neiswander and Dole at Rockefeller, offered an explanation that resonated completely with my own experience. There is a stigma against addictions, addicts, and sadly, treatment providers. I peered into Marie's eyes, a sense of kinship building. At age 34, I was an aspiring addiction physician looking for a role model, and Marie's story drew me in with her promise of a medical fairy tale about a pioneering, revolutionary physician who broke the rules on behalf of a group of patients who mainstream society would prefer to ignore. On the surface, her story seemed equivalent to those portrayed by Hollywood in And the Band Played On and the Dallas Buyers Club, inspirational movies about the power of medicine to fight injustice. Yet, it wasn't the medicine that really pulled viewers in. but a charismatic protagonist, usually a white male, who fought the system and led others toward a better future. Hope fluttered in my chest. Had I finally discovered a version of the story with a female lead? I had always craved a female boss or mentor in medicine, but they were hard to come by. It was only recently that women and men matriculated at equal rates into medical school, and women are still much less likely to be chairs, directors, or full professors. Of my residency's 20 or so faculty members, only 2 were women, and neither held a position of authority. In the community EDs where I later worked, all the directors and chairs were men. Although the men who had mentored me were wonderful, there were some things they would never understand. They would never have to pump breast milk while on a busy ER shift, or feel the same pressure to choose between family or career. And leadership strategies that worked for them would not always have the same effect for me. I saw Marie's life as a potential key to all my questions, and I began to unravel it like a detective. I searched far and wide for clues, turning to books, archival articles, and interviews. Who was she, professionally and personally? What could she teach me about the history of addiction treatment and today's related inability to stem a worsening epidemic? About what it means to be a doctor facing the double stigma of treating addiction and being a woman? Why did I get the sense that I was fighting the same battles with myself, my patients, and medicine at large that Marie had already fought more than 50 years ago? I'll stop there. Thanks.
Thank you so much. So when you left USC, I knew you had matched in emergency medicine and you were going to be an emergency medicine doctor. And I know you still are one, but you have a new specialty. And so can you tell us about what drew you to that and how it unfolded for you?
I think the most influential moment was when I was practicing in the county emergency department in Oakland, which is Highland Hospital. That's where one of the places I worked after fellowship. I was working there. We had a patient who came in the throes of opioid withdrawal. He was vomiting and moaning and sort of shouting and laying in this fetal position on the side of his stretcher. His nurse was annoyed that he had vomited all over the floor in this shared room. And one of the residents came over to me and after seeing the patient said, I would like to start buprenorphine for him. And I said, well, what is that? I've never heard of this medicine. I've never given it. What is it? And he explained to me, it's very simple, I was okay, fine, whatever. And so he gave it to him, and within 30 minutes, the man was dressed, put together, he was smiling, he was asking to go home. And even in the emergency department, we think things have fast turnarounds and quick dispositions and all this stuff. Nothing had been that remarkable of a transformation. And he looked great, he felt good, he thanked us, he was appreciative. This was not the typical experience I had with people who use drugs. Usually when people came in who were using drugs, I felt disdain towards them or just discomfort, not knowing how I could help or what I could do, a little frustrated, assuming that I'd probably see them again in a few days, feeling like I didn't have tools to help. And also, the only thing I had really been taught about opioids was that we weren't supposed to give them out anymore. This was 2013, 2015, that part of the opioid epidemic where we're swinging the pendulum the other way and telling doctors not to prescribe, not to give opioids. So I thought that was the solution, but it wasn't working. I had these horrible experiences with people and I couldn't figure out how to make it better. But with this medicine, suddenly the tables had turned. Suddenly it was a positive interaction. I had something that could actually help with withdrawal and keeping people sober if that's what they wanted. So I just wanted to know more about this medicine. I started giving it out more, started having more positive experiences in the hospital, patients hugging me. Again, that is not something that happens in the ER very often. And I felt like I was also kind of experiencing burnout. This was a couple years after my fellowship had ended. And I was just driving from shift to shift, random hours across the Bay Area. And I finally felt like I had a purpose or something bigger than just going shift to shift. So I became really interested in addiction medicine, started practicing it, and now it's a big part of my practice.
Do additional training?
Kind of. I I didn't do another fellowship. I finished one in EMS, and I looked into it kind of, and my husband was like, no, you are not doing another fellowship, please. And at the time, you could grandfather into addiction medicine, so that's what I did. So I worked at a startup. We were doing buprenorphine remotely, trying to increase access that way. And then I worked at the Methadone clinic, and then lots of my QI projects in the emergency department and in EMS were related to opioids, so I could count those hours towards it. And I took the board exam.
I don't know if you'll talk about this or if we should maybe, for people who don't know what buprenorphine is, do you want to just talk about that a little bit?
Yes, good. Yeah, so both buprenorphine and methadone are medications for opioid use disorder. They're both opioids, but pharmacologically, they're very different than illicit fentanyl. Illicit fentanyl, we don't know what's in it. There's all these different analogs. It's not a safe supply. It also doesn't last very long, so people are using 20 to 100 pills a day throughout the day. With methadone and buprenorphine, they have very long half-lives. People can take them just once a day. They just feel normal again for the first time. I've had so many patients who tell me, with this medicine, I just feel normal. Like they had stopped enjoying the high of fentanyl a long time ago, but they need it so they don't feel sick. And with buprenorphine and methadone, because they are opioids, they don't feel sick. They are opioids, but they're longer acting, so people don't get the high, they don't get the low, they just feel stable. And buprenorphine is also a partial agonist. So with methadone, oxycodone, morphine, heroin, fentanyl, the more you take, the more of an effect there is. If you think about like a dimmer switch, you're just turning the light up all the way the more you take. So that's how people can overdose. They can take too much. But with buprenorphine, it's a partial agonist. So the dimmer switch kind of is just halfway. I had one patient who took his whole week's supply of buprenorphine at once and nothing really much happened. So it's harder to overdose on. It's safer than oxycodone, safer than hydrocodone, these other opioids that we prescribe a lot from the ER.
Can you tell us, because a huge portion of the book is really about your, it's your own story, but it's also the story of this woman who you found in history with a sort of similar, potentially similar journey. How did you discover her? What did you do to get this, all this research on her, and what effect did that have?
So I found her that night when I was looking, because I went to the methadone clinic. There was also like bulletproof plexiglass everywhere, and it just felt so different than every other medical environment I had worked in. If you go to a dermatology clinic, it feels very different than the methadone clinic. And I was like, why is that? Why does it feel so carceral? Has it always been this way? Why do I have this stigma against methadone that I didn't realize I really had? Like, why is it that in med school, none of us were aspiring to work at one? I feel like the impression I had internalized, the hidden curriculum, was that only doctors who have lost their license go work at a methadone clinic or something like that. So I was like, where does this come from? Why do I have this bias against methadone? Why do we all think bupe is superior, all of us who are like now getting into addiction medicine? And has it always been this way? And it has. I found all these newspaper headlines from the 60s and 70s that were very stigmatizing, saying like, someone dies, and someone was stabbed in line at the methadone clinic. Baby overdoses on methadone and dies. Like all these headlines are very inflammatory. And so I just happened to find this article, and I was searching through the archives, and I just realized there was a story there. And in my MFA program, we were taught that if you feel called to some story, to go chase it and to see why, to see what it's teaching you. And so that's what I did. There wasn't that much material on her. Although there was a blip, like in the 60s and 70s, she was kind of a big deal. Vogue had 2 different biopics about her, and for like a doctor to be profiled in Vogue doesn't happen very often. She was pretty glamorous though. Her ex-husband was a writer at the New Yorker, and one of their colleagues wrote a biography about her. So there was a little bit of a flash when methadone came out, but then it got quiet. No one talked about her. I had never heard of her. And I was like, why isn't this woman's story, why isn't her legacy being talked about? Why has she been forgotten? So that's a story too. Some of the men I interviewed thought that methadone maintenance had really been her husband's idea, and there's no way it could have been hers, which is just like a story as old as time, I feel like, with women scientists from back in the day. So I started looking through this material, and then I found a historian who had written a short article about her in the 90s. And he offered to send me a whole box of source material with interviews that he had collected for that piece. And that was the coolest thing ever, to rifle through that. And then I interviewed one of her coworkers, who was also her bridesmaid. Interviewed another New York writer who knew both her and her third husband. It was pretty fun talking to them.
So with respect to who gets credit for this work, where does that stand? And does she finally get her due recognition, do you think?
I don't think she has. I mean, that's what I'm trying to do with this book and trying to tell her story, is to like keep her legacy alive and tell her story. But most of the people I talked to thought it was his idea, but they were men. The one woman I talked to was very clear. She was like, no, this was definitely Marie's idea. I'll never know. Most of their colleagues died a long time ago. But I think it makes more sense that it was her, because she was the one who had worked in addiction medicine. She worked at the U.S. narcotic farm, which is a whole other wild story, where she first had exposure to methadone. Vince was not an addiction doc. He was a metabolic researcher. And so although he had a lot of research experience, he had a lot of political clout in medicine, he made this happen, that they could sort of break the rules of the DEA's forerunner and do this research. He wasn't the one who had any experience with addiction. It was all her.
And as you reflect on your own journey, how do you feel about, the work you're doing and the work that, it's sort of inspired by her and your own legacy to be?
Legacy is a big word to be throwing around, I feel like, but I was sort of struck by how much we had in common. Just like the Bureau of Narcotics and Dangerous Drugs came after her and Vince and told them to stop their research. I had a medical board come after me and tell me I was prescribing prison heroin, which is how they referred to buprenorphine. That happened. Both of us lacked female mentors in medicine. We both sort of fell into addiction medicine by accident. There were lots of parallels. It was still much harder for our patients to get the treatment than the poison. Neither one of us had really learned much about addiction in medical school or residency. So I was just really struck by how similar our stories were, despite, she was practicing medicine in the 40s to 60s, and here I am now, and nothing has changed. Yeah. Although some has changed, there is some hope. Yeah.
The other thing I thought was really interesting, and one place I'll quote you here actually. This has to do with the importance of stories and in shaping identities. And you quote someone who is a French Marxist philosopher, Louis Althusser, suggested that texts are one of the primary ways in which people shape their identities. When a text hails us, we turn around as when we hear a familiar voice in the street. There's a sense of recognition, of being seen. After all, it was a story at a book club that hailed me. Could a story about methadone and Marie do the same for others? So I really found that lovely. We talk in narrative medicine about, we often quote Roy Schaefer, who's a psychoanalyst, who talks about the self as a telling. And so you come into identity through stories. And I wondered if you could just reflect a little bit on that, given your own journey.
Yes, and thank you for highlighting that quote. I love that quote. My editor wanted me to take it out. I was like, no. Good, thank you. That's what I was trying to do with this book, is really part of me, the thing that inspired me to write this, and the way that I did, was that I kept trying to change other doctors' minds and try to encourage them to start buprenorphine and methadone on our eligible patients in the hospital. And I would just run into these horrible obstacles. At one point, when I first came to the University of Arizona, they weren't doing a lot of these treatments in the hospital at that time. I started someone on methadone in the hospital, admitted them, and then the hospitalist told me, well, we can't give methadone, we're not authorized, so we're just gonna discontinue this treatment. I could tell them, yes, you are authorized, here's the federal code, but who are they to believe me? They don't know me, why should they believe what I'm saying? So I just kept running into obstacles like this. Once I sent someone home on a prescription for buprenorphine, and the pharmacist refused to fill it because I wasn't the patient's primary addiction doc. I was just an ER doctor. So sometimes I felt like I was saying the evidence until I was blue in the face, bringing out statistics, bringing out research papers, evidence-based trials. That's what we learn in medical school. That's sort of our currency, is research and evidence-based medicine. So I thought that would sway people's minds, but I was noticing it wasn't all the time. And so I thought maybe this is from stigma. It's not about reason. It's not about logic. It's stigma, plain and simple. And that's not swayed by facts and figures. That's something of the heart. And maybe a story could get in there in a way that the numbers couldn't. So that's why I tried to tell it in this way instead of the traditional scientific journal articles I'm used to writing.
Another thing that struck me was something you said about the lack of a plot in chaotic drug use. And I wondered if you could just expand on that, because I thought it was such a helpful way to understand some of the chaos that surrounds this field and how to navigate it.
Yes, and that is something else that comes up a lot of the time too. And I'm trying to convince skeptical clinicians about giving out Narcan or starting bupe or methadone. Sometimes I would cling on to those fairy tales that we hear, people who are in recovery and doing really well. That was initially the story I was repeating. You know, someone comes in sick, a doctor swoops in, sort of like a hero or the savior, gives them this medication, their life gets back together, they go back to school, they reunite with family. And although that does happen for lots of people, it doesn't. They might be on methadone or buprenorphine temporarily and it helps, but then they don't get the prescription refilled for one reason or another, and they relapse, they get back they're on the streets again, they miss their clinic appointments. But I was sort of hiding that story because I was trying to convince other doctors to get on board. But ultimately, I think I was doing a disservice by just painting this traditional hero story over and over and over again, because it's not real. And also it reinforces this hierarchy that puts doctors on the top. And I just don't think that's the way we should be practicing medicine at all, especially not in addiction, but in any field. So by the end of the book, I'm sort of coming around to telling the story a little more honestly. And that's okay. It's okay if we're not the savior. It's okay if things aren't fixed completely. They are better. We're moving towards any positive change, taking more of an approach of harm reduction.
There's a lot of the story that you share that is, I got anxious on your behalf. I mean, there are things that you were working on that could get you in trouble or did get you in trouble. And you talk about working from inside the House of Medicine and outside the House of Medicine. So I thought maybe you could talk about that a little bit too.
Yeah. There's a quote that I have over my desk that says, "The master's tools will never disable the master's house." And I always was struggling with this. This was sort of one of the existential questions that led me to writing this book. Like those movies that I mentioned where the doctor's sort of the hero or thing. There was a book about Paul Farmer that sort of led me to medicine in the first place. But these doctors are always portrayed as heroes. But then you have this other mindset that's, the change is not coming from the top down, it's coming from the ground up and democratizing and that kind of thing. So how do you deal with these two dealing narratives? How do you put this together? And how, as someone from inside the House of Medicine, I'm in the master's house, what is my role? How can I leverage the tools that I have to speak for those who maybe don't have them, while not just reinforcing this hierarchy that causes all these problems anyway? The hegemony of oppression. How do I do my job, use the power without reinforcing that? And that is the constant question.
Yeah, something you don't figure out the answer to.
Yeah.
Oh, okay, now I do that.
Yes, exactly. But I do think harm reduction is an approach that we can take to sort of get us there, because harm reduction, we think about it a lot as a practice, right? As giving out Narcan, but it's also things like wearing a seatbelt, putting on sunblock. There's many forms of harm reduction. It's just things we do to mitigate the risk. But it's also a philosophy, which puts the patient as the expert. Us as the medical professionals are just technical advisors. We can ask them what their goals are, give some suggestions, but ultimately it's their choice. So that's the philosophy of harm reduction that goes with this practice, and moving towards any positive change, even if it's not the change that we as the practitioner think we want for them.
Yeah, and that philosophy is really, what we hope motivates all of care, primary care, that we should always be thinking about goals of care and patient-centered work. So What's the lay of the land now? So like what's the status of federal legislation? Where are we? Are we making any progress, do you think, towards a more sane and healthy methods of treatment?
I don't know, maybe small changes, but so when Marie and Vince came out with methadone maintenance in the 60s, there was a brief surge where it really spread across the country. They were opening methadone clinics left and right. The Nixon administration spent more money funding treatment than instead of policing it than any administration before or after. So there was a brief, oh, this is very exciting, methadone's gonna make a difference. But then there was lots of opponents of methadone maintenance, and they started to use regulation as a way to curtail it and limit its access. It's one of the most heavily regulated outpatient medications in America. Half of the country doesn't have access to a methadone clinic. The whole state of Wyoming, there's no methadone clinic. In Arizona, just the major cities pretty much have methadone clinics, so people might have to drive 2 hours each way to get to one. And that really hasn't changed much. That's something else that hasn't changed much since Marie's day and now. There's been incremental changes. According to federal regulations, it's now easier to get take home. So instead of a patient having to go every single day to the methadone clinic for directly observed therapy, they can get take homes much sooner. But most of the clinics haven't actually implemented that. So although the federal legislation makes it possible, few of the clinics are doing it. They're not reimbursed at the same rate for take homes in certain states. So there's still obstacles. A few years ago, the American Society of Addiction Medicine was supporting a bill called MOTA, Modernizing Opioid Treatment Act, where they would have made it so any addiction physician could write a prescription for methadone that could go to any pharmacy, Walgreens, CVS, Walmart, whatever, make it more accessible, but it didn't pass.
Sad.
Yeah.
Okay, my last question, then I'll open it up. You, in researching Marie, found a lot of really interesting stuff about her. She's very, very compelling character, had many sides to her. And at one point you're sort of pondering how to understand her. And you used the term radical empathy. And that made me think about some other things in our narrative medicine world, and I had some thoughts about it, but I wanted to hear you tell us about radical empathy.
We don't have to understand people. We don't have to agree with all their choices. It's not saying that we're not condoning their actions if we don't agree with them, but we're just letting them be who they are. And so I could practice, which is sort of, again, another tenet of harm reduction, and I could practice that with her.
Yeah.
Because even though she broke glass ceilings time and time again, both as a woman in medicine and as an addiction physician, like she made a lot of progress in addiction medicine, even beyond methadone maintenance. She also did some pretty crazy things, like she wrote this anti-feminist book called The Power of Sexual Surrender, which she told women to not work outside the home. They should just be available for their husbands. They should just look nice for them. They should never get a divorce. And this is, none of this stuff is stuff she did. She had 3 divorces, 4 husbands, worked outside the home, never had children. So I didn't understand this book. It's still available. You can buy it on Amazon. People are still leaving positive reviews about it, which is really funny too. I don't know why she did that, Yeah.
I just love that you approach the subject of your study, this in terms of writing about her, and the subject of your work with this recognition that you can't understand it all. And so it made me think about what we in narrative medicine call, and this is the words of our Columbia colleague, Sayantani Dasgupta, narrative humility. And we talk about the fact that, I'm quoting her now, that stories aren't objects that we can comprehend or ever become entirely 100% competent regarding, particularly when those stories are oral interchanges with real life people on the other end. Taking a position of narrative humility means understanding that stories are relationships we can approach and engage with while simultaneously remaining open to their ambiguity and contradiction, and while engaging in constant self-evaluation and self-critique about issues such as our own role in the story, what we bring to it, including our own biases. And I just feel as if this book is an example of that kind of humility, both in your research of your subject, human subject, and the issue of the addiction and addiction medicine. So I highly recommend this book. It's a wonderful read, and I learned a lot about addiction medicine, but also about these many factors and how we best care for people. So thank you.
I love how you put that. I love that quote as well, because I think that's something that med school doesn't always teach, even though we strive to, is the gray area and the art of medicine and the ambiguity. You know, when we're studying for the boards, USMLE, it's just there's always a right answer. But in the actual practice of medicine, that's not how it is at all. And I think literature and the arts really helped me fill that gap in my basic medical training.
Thank you, Melody.
Thank you.
So, any questions? Yes.
I cannot wait to read this book. This just sounds so fascinating to me. But my question is, and maybe I missed it, how are there obstacles to methadone in the clinic? I mean, usually when legislation doesn't pass, it usually has to do with money or cultural bias.
There's both of those.
There's both of those, but isn't there evidence that shows that having functioning individuals in society is cost effective?
Yes. There is that evidence, but it's like who's the payer? It's like the wrong payer problem, I think. Is it the people who save money are not the ones who have to pay for the intervention?
Okay.
So it's like, yeah, the hospital will save money if people are in treatment and in recovery, but they're not the ones funding the methadone clinics.
Okay.
And one of the biggest opponents of MODA was the lobby of the methadone clinics because they don't want to lose their patients. So there is money.
So it is about money, and it's also about bias.
Yeah, there's a lot of
population.
Yeah, right. There's a bias against this population. Lots of people still think addiction medicine is not within the house of medicine. You know, that's why I think in medical school I had 1 or 2 lectures about addiction, which sends the message that addiction is not medical, right? You go to behavioral health or you do therapy or something, which is important too, but it's also, you know, I think everyone should go to therapy, but that's beside the point. So it just said, there's a historical reason, which I go into here also, the historical reasons why there's this deep stigma against methadone. It's 100 years old.
So I wonder, I'd like to know how often, I guess particularly with take-home methadone, how often people get into trouble with that?
Most of the time people don't get into trouble with the take-home methadone doses. And so during COVID, during the pandemic, they loosened regulations for methadone so people could get take-home sooner because they don't want people infecting everyone at the clinic. And everyone liked it. The staff liked it. The patients liked it. I think there was actually less overdoses. And the idea is that you wouldn't necessarily do this for all patients, just the more stable ones. Because you could get into trouble with it. And like a kid could drink it and overdose. People could share it with other friends. But I don't think there's much of a market for getting high with methadone because it's so cheap and easy to buy fentanyl. Why would you mess around with methadone? But it's certainly possible.
I think you got very high with methadone.
People who use opioids don't get high on methadone, but if someone was opioid naive, it could be too much still. You wouldn't get the same like dopamine surge. It probably wouldn't feel as good.
I wonder if you could talk about your other creative writing endeavors.
Sure. Yeah, so I got my MFA, my Master's of Fine Arts in Creative Writing. I did that after my fellowship. I think that's another reason my husband was like, please, no more fellowships. You're also doing this master's. But the MFA was really fun. It was like probably the most fun thing I've done in a long time because I didn't feel like I had a point. There was no, like I wasn't doing it to get somewhere. I was just doing it because I enjoyed it. And just talking about poetry with people in this historic classroom under the redwoods was just really lovely. And other projects, I'm working on a piece of journalism about the history of naloxone or Narcan. That's coming out in a magazine next year. I've written some personal essays. And I'm working on another memoir right now. Yeah.
That's great. I guess the follow-up is advice for medical students.
Yes.
About how to take care of themselves.
Yes, how to take care of yourselves. I mean, for me, writing was a big part of that practice. And I wish I had kept it up in residency. I wrote quite a bit in medical school, just journaling what was going on, writing letters. But in residency, I felt like I was too busy and too depleted to do that. And now it's just sort of like this gaping black hole in my memory. So I wish I had kept it up. But it's hard. It's hard with the time constraints. I think the system as a whole needs to change to support people. You know, I don't like this idea that it's up to the individual to stay healthy. We just have to meditate more and then we'll be fine. We won't have burnout. You know, it's like reframing it as a systemic issue it is.
Any last words for us?
Thank you for coming. And I'll be around if anyone wants to come up and ask a question privately. And yes, please buy the book or check it out at the library, Mother of Methadone. I'd really appreciate it. Thank you.